Good afternoon, everyone. Welcome to the Community Paramedicine Insights Forum for April 2017. This is Kevin McGinnis with the National Association of State EMS Officials. The program is also sponsored by the National Organization of State Offices of Rural Health and Center for Leadership, Innovation, and Research. Today, we are pleased to have two presenters. First will be our very own, my partner in crime on CPIF, Gary Wingrove from Mayo and the Paramedic Foundation, who will be doing an update for us on sort of worldwide happenings in community paramedicine. He will be followed by David Ezell, who's an education consultant for the North Carolina Office of EMS. North Carolina presented a poster on community paramedicine research project, statewide project that they have done. And it caught my eye, and I thought you all would be interested in hearing about some of their findings. And with that, I just want to note that this approach to programming is going to kind of take over the Community Paramedicine Insights Forum. For the first 5 years, we really focused on establishing new systems, legislation, and other ways to start up community paramedicine types of programming. And we'll continue periodically to revisit some programs that have been on the program as some of the early builders and see how they're doing. But what we're really interested in now is turning to those programs who have been going for a while and finding out what their data is saying. You started, you're doing it. What kind of impact are you having on patients, on the system, on your finances, and the ability to sustain your program? So if you have knowledge of any program that's been around out there, we might want to hear from them if they have any kind of results from their program, whether it's impacts on patients, the service, the system, or what have you. They don't need to be published results. We're interested in anything that people have found out that look like legitimate effects of community paramedicine programs. So have them get a hold of me, McGinnis, McGinnis, at NASEMSO, NASEMSO.org, McGinnis at NASEMSO.org, with those suggestions. So that's what we'll be starting to feature more frequently, if not exclusively, in the future. So let us turn to our first presentation, Gary Wingrove.
Thanks, Kevin. I'm going to do a couple of things today. I'm going to talk a little bit about changes that are upcoming in the curriculum for community paramedics, and then do sort of a broad brush of what happened at IRCP in England in February, and fill in a couple of other details. So we had the 13th annual meeting of the IRCP, along with the Ambulance Leadership Forum of the Association of Ambulance Chief Executives. Their meeting was in Warwickshire, England this year. And this is the first time that an IRCP meeting has been dominated by research, and so I see that as a natural growth spot for us, but also a very exciting one. Back in 2005, when Kevin and I and others started talking about community paramedicine, often we'd go to a conference and the room would look like this. And it's not that way anymore. The rooms are usually packed, and there's lots of things going on. So we have over a decade now of international collaboration, and we're starting to see our governments do some investing. In Minnesota, we have a shared savings model in our Medicaid program. That's at North Memorial, and they've been on CPIF before, sharing their information. You'll hear a little bit more about some of their new programs today. And so in that model, North Memorial has about 10,000 of the sickest Medicaid patients in Minnesota that they follow. They have embedded their community paramedics in their accountable care organization clinics. And they see patients who have 3 or more comorbidities and are on 10 or more prescribed medications. And the way the system works here is that if North Memorial can produce a savings that's less than what Medicaid paid in the old system under fee-for-service, and they get to share in that savings. And they've been through 3 rounds of that now. The first payment in shared savings they got from our state was $800,000. The second year it was $1.5 million, and the third year $3.4 million. Australia has invested $4 million in community paramedic workforce grants. The province of Ontario, $6 million to expand community paramedic programs, and they're up for another round of funding. And then, of course, we had 2 rounds of innovation awards through the Centers for Medicare and Medicaid Innovation, $13.5 million for the first 3 projects in 2012, and another $29.2 million in 2014. And so we're also doing some collaboration between the 4 mainstay countries of IRCP, the U.S., Canada, Australasia, which includes Australia, New Zealand, and New Guinea, and the United Kingdom. Last year, when we did our meeting in Saskatchewan, in Saskatoon, we had a meeting the day after where we invited colleges to come in and start talking about aligning the paramedic, not the community paramedic, but the paramedic curriculum. As more countries start requiring degrees as entry to practice, we wanted to start a process whereby the universities and colleges could talk about aligning those degree programs to increase the mobility of paramedics between countries. And so we're doing the second meeting of that, and we now call that group the Global Paramedic Higher Education Council. We'll be doing that in a few weeks on May 11th in the UK. It'll be immediately following the United Kingdom's College of Paramedics Conference, and we expect about 7 countries to participate in that meeting. Also, another topic that started to dominate the international agenda is paramedic suicide and paramedic health and safety. And you'll hear more about that as time goes on. We have a paramedic suicide attempt reporting tool now on the event website, emseventreport.com, and where people can report suicides that they know about, or if someone did an attempt themselves, they can do self-reporting on that website. So that is set up for all 4 countries to participate in. Of course, we have a language that we use at IRCP. We have to have a common language because if you look worldwide, there are hundreds of different names that are used for people that work on ambulances. And this is what our language looks like. Primary care paramedic is a basic life support provider, the entry level. Intermediate care paramedic, an advanced life support provider with limited skill set. An advanced care paramedic is an advanced life support provider, sort of the standard person you'd see on an ALS ambulance. A community paramedic is one of those 3 along with some other skills, and then we call ambulance services paramedic services. So we have a rotation that we usually follow that goes United States, Australia, Canada, the United Kingdom. And since we were just in the United Kingdom in February, our planned rotation was the U.S. in 2018, Australia 2019, Canada 2020, and the United Kingdom in 2021. This chart is a little hard for you to see, but it sort of maps out the months where our meetings have occurred since 2005. And the UK put us in a little spot this year because they went in February instead of our usual pattern of sometime between May and October. And so if we wait until 2018 to have another IRCP meeting, 20 months will have gone by. We thought that was a little bit too long. So in the UK, the IRCP group voted to have a second IRCP in 2017. And so we will be doing that in October along with EMS World. IRCP will be October 15th, 16th, and 17th. We're dedicating the 17th entirely to research. And EMS World will make that announcement any day now and set up a registration process. So if you're interested in participating, EMS World naturally draws 44 countries to its main conference. So we're hoping to have a lively international presence at the IRCP meeting located with them this fall. That will change our rotation a little bit. We won't call it an annual meeting anymore because we're having 2 this year, but that will put us in Australia next year, and they actually are planning to meet in New Zealand. New Zealand is a treat if you've never been there. It's one of the most spectacular places on the earth. So I'd encourage you to think about planning for that early, and then Canada in 2019, and back in the UK in 2020. So we've had some landmarks that have gone by. In 2005, the international conversation started when IRCP was formed and met for the first time in Nova Scotia. The first curriculum and pilot of that curriculum was in 2007. The second version was 2009. The third version in 2012. In 2015, the BCC TPC, which is now known as the International Board of Specialty Certification, created the Community Paramedic exam. And in this year, we'll be releasing what I call the second generation of the curriculum. It's going to be the 4th version, but it will be different than the ones prior, and we'll have 10 modules instead of 7. Along with that, some things have changed within the industry, and we have created a couple of more courses, and we've also done some alignment with degrees. And so we're hoping to push the colleges towards some of the degree alignment. One of the things that happened that we didn't predict well was how much activity there would be around community paramedics working with 911 callers. And the full curriculum is meant to be for those that are immersed in primary care as well as doing 911 calls. And so we have created a new curriculum that is available at the EMT level that we call primary care technician, and at the paramedic level that we call community paramedic technician. And those are a subset of the full course and are intended for the people that are just going to try to impact the 911 caller in some form or fashion. The current curriculum that you may be familiar with will be rebranded the Community Paramedic Clinician. And then we have 3 names for people that go into degrees through the Community Paramedic Program: a Community Paramedic Practitioner, Advanced Practitioner, and Consultant. You can get a full layout of what that system looks like on mobilece.org and download several page document that talks about the various levels. Here's where it is in sort of a snapshot. The primary care technician course, which again is intended for EMTs that are going to do something with 911 callers like treat and release, treat and refer, treat and transport to an alternative destination, or assess and report. That'll be a 48-hour course and is intended for a certificate or diploma. The community paramedic technician is sort of the same course, but at the paramedic level, an 88-hour course through a certificate or diploma. The existing course rebranded to community paramedic clinician remains at about 314 hours. Then the community paramedic practitioner name is reserved for those who exit with a bachelor's degree, the community paramedic advanced practitioner, a master's degree, and then the doctorate level, Doctor of Community Paramedicine. And we expect, you might think that's a long ways off, but we think that the first students might enter that doctoral course in 2018, somewhere in the United States. So a little bit about those and what you'll see if you download that document off mobilece.org, a little bit about each of those levels. This is the practitioner level set up for a baccalaureate degree, and it continues all of the work within the community paramedic technician and the clinician programs, and then examines processes and tools in planning and evaluating culturally competent health. At the master's level, it's a postgraduate degree and entry level for educators and program managers, and also prepare people for administrator, health policy expert, or clinical leader roles. And then at the doctorate level, it will provide opportunities for employment in higher education, healthcare and research, hospital settings, and other venues. So some exciting news there. And then the last thing I wanted to do was give you an overview of the sessions that we had at IRCP in England this year. And I'm going to do that rather quickly, but at the end, I'm going to show you how to navigate the website. We have all of the PowerPoint presentations posted so that you can grab those. And we have streaming video of almost all of the sessions. We had a couple of technological glitches, and 2 or 3 sessions either didn't record or didn't have audio, but almost all of them are there. So what I hope to do at this part is lay out for you the sessions that we had, and then just tell you briefly about each one. And then if you're interested, you can go to the website and either look at the PowerPoint presentation or watch the streaming video. So we had 5 different categories of sessions. The first was on standards and data, and our first speaker was John Clark from the International Board of Specialty Certification, and he basically talked about certification within the practitioner levels and the community paramedic certification exam that is offered through IBSC. Then we had a presentation from England, James Hayward, Philip Strange, and Carol Robertson, developing community paramedicine at a regional level. And this presentation was about measuring change and improvement, choosing data and planning improvement projects, monitoring and evaluating changes, about lessons learned, recommendations for the future, and the reality of the new role from the practitioner perspective. Then we had a session that I was part of, as well as Kurt Bashford from General Devices, Dudley Smith from CAMPS, and Josephine Kershaw from the Christ College of Nursing. And we talked about the changes I just reviewed with you in the curriculum, and also technology and standards related to agency performance. And then the last one in that session was Pierre Poirier from the Paramedic Association of Canada. The Canadian Standards Association is an ANSI body, and they are just finalizing. In fact, the final vote is later this week, a standard for community paramedicine programs. It will be a North American standard once it's released. We did a fairly broad distribution of the draft standard a couple of months ago in which people could make comments, but we expect the final product to be released sometime soon. And since that is an ANSI organization, it will be North American wide. Our second set of sessions was about integration. The first one was by Dr. Peter Tangy from North Memorial, and he talked about community paramedics and the social determinants of health and using them in navigation. The second one was about paramedic professionals and medical assistants in dying. Canada has had a law passed, it was Canadian Bill C-14, that provides for paramedic professionals and medical assisting with medical assistance in dying, a rather interesting concept. The third one was from a pilot program that the place where I work is doing in Northwest Wisconsin. The fourth session in that group was about WeCare, and that's in Indiana, and they talk about the community risk assessment, building coalitions, doing program development, data collection and analysis, and then reassessing community risk. And then the final session in that group was building EMS urgent care in the Navajo community in New Mexico by Emily Pierce and Dr. Chelsea White, a paramedic turned physician. And they talked about building a program in a Indian nation that has very sparse resources, and this one was focused on wound care, cold and flu illnesses, mild hyperglycemia, urinary tract infections, allergic reactions, and sprains and strains. Session C was about innovation. The first session was again Dr. White and Emily Pierce. They talked about another tribal program that they worked on. It was involving the Indian Public Health Community Health Resource staff and their workflow, visits that were focused on patients needing complex wound care, and then how the community health representatives assisted people in getting to their appointments. The second session was by North Memorial. They have a part of Minneapolis in the projects, the North Minneapolis area, and there's a several square mile area in that part of town that doesn't have grocery resources. They have one grocery store, and so the community is building a second grocery store, and they're placing community paramedics and pharmacists in the grocery store and helping people navigate their care. If you're in an urban environment, that would be a really interesting session for you to watch the recording on. And then the next one has to do with paramedics in non-traditional environments. This was about a group home that North Memorial works with called Vale Place. They have community paramedics on site twice a month doing health screenings, primary care, and also education sessions. And then session 4, again, was Dr. Tangy, and he talked about the determinants of health in pediatrics, the social determinants of health in pediatrics, something we don't hear about very often. And this particular program that they do is on RSV. Session D was about evaluation, and the health call and WeCare people did that session as well from Indiana, John Logan and Josh Mailing. And they have a really interesting data system, a scheduling system, a really integrated platform that they did an overview of, and this session was all about applying technology in the community paramedic environment. And the second session was by Joanna Blodgett from the University of Manchester and Duncan Robinson, and they talked about safer care closer to home in avoiding taking patients to the emergency department, and their program was about referral and also self-care. And then finally, our research agenda was the last one, and Dr. O'Mara from Australia, some of you may have seen him if you've been to any of the IRCP sessions in the past, and they did a program, I can never pronounce their names, but it was the Wedderburn Paramedic Community Support Officer Program that they started in April 2016, and they have a new role for community paramedics there. They transitioned the community emergency response team into an ambulance community officer program and developed networks in these rural parts of Australia, and talked about the impact that they've had on patients' lives there. The second session was by Matt Leonar from Canada, and he talked about contrasting the community paramedicine programs around Canada. Very interesting. They have different ways that they do community paramedicine in Canada, and a little bit differently from us, they have some programs that are sort of standalone, that are modularized, that are making their way across Canada. Interesting session as well. The third session was from the UK again. Andy Irving from the University of Sheffield talked about alcohol-related attendances and a program that they have done in the UK with community paramedics working in alcohol intoxication management service. The fourth session was a review of a community paramedic program in the Boston area. Matt Goodrose did that session. He has spoken at IRCB before when he was the manager of the program in Boston. He now works for the organization that funds that program, the Commonwealth Care Alliance. And so it's interesting to see someone go from practitioner manager on the provider side into the insurance side or the payment side in funding a program. But this particular program is focused on dual eligible patients that have multiple comorbidities, a lot of behavioral health, and high acuity care. And then finally, the last session that we had this year was by Matt Leonar, Care Planning and Case Management, and this was all about an assessment approach. So that's sort of a broad overview about what happened, and if you would like to look at some of these sessions, you can go to ircp.info, then you'll click on Meetings, and you'll see this page, click on 2017, and then you'll see this page, and the PowerPoint presentations are on the left, and the sessions that we have streaming video of are on the right. I'd like to point out the one on the right side at the very bottom. We had some people from the Netherlands show up at IRCP this year, and they had a presentation with them, so we took them up on it. And we have a bonus video, we called it because it didn't have a session number, but it's about EMS in the Netherlands and very thought-provoking approaches that they're using in the Netherlands. So I'm going to pause there. We'll pass it to David, and then afterward, we'll see if you have any questions. David, it's all yours.
Yeah, I appreciate that. As you said, my name is David Ezel. I work here with the North Carolina Office of EMS. One of my primary responsibilities is helping to oversee the community paramedic programs here in North Carolina. This past year, the General Assembly here in North Carolina tasked us with putting forth a grant program to try to see some estimated savings for what community paramedicine could cost or could save the taxpayers here in North Carolina. Some of you may have saw Dr. Tony Fernandez presented some of our research over at NCOEMS. He put together an abstract, and we had a poster presentation there, and that's kind of where this stemmed from. And after presenting that, they mentioned us coming on here to talk to you a little more about some of our findings. This is just some of the background information. These are some of the folks that helped put some of this stuff together, primarily some of our staff here at the North Carolina Office of EMS, as well as the staff over at the EMS Performance Improvement Center in Chapel Hill. One of the first questions I get asked quite often when I talk to different folks about community paramedicine in North Carolina is, they say, well, what type of legislation do you have in place? How is it you are allowed to do community paramedicine in North Carolina? So the way it works for us here in North Carolina is we actually allow community paramedicine to function based off of administrative code. There's the code number there. If anyone particularly want to look up, it's our 506 rule is what we call it. And in that rule, it basically says what the practice setting is for paramedics in North Carolina. And if you want to note, in bullet point number 4 there, it tells you that you can operate in any residence, facility, other locations, any type of prevention initiative within the community and the public health system. And the way our office interprets that, and the way the Attorney General here in North Carolina interprets that, is that can be basically any type of program, and we consider that to be community paramedicine. Mobile integrated health, however you want to look at it. A little more background on that. In North Carolina currently, North Carolina has 100 counties. We also have the Tribal Cherokee, so we have 101 different EMS systems in North Carolina. So we have about 26 counties that have some type of community paramedic program going on in North Carolina. And they could be in various stages. They could be active programs that are currently functioning. Some of those may be programs that are looking into it or in some set stage of development of trying to roll out their program. But I feel like, we've got basically a quarter of the state or more that's working on trying to get these programs out there, and it's continuing to grow. So let's talk about that grant a little bit. Basically, the General Assembly designated a grant in North Carolina. It designated $350,000 for community paramedic programs. In that legislation, it specifically designated $210,000 for New Hanover Regional EMS, which is the Wilmington, North Carolina area, if you're familiar. And it also designated $140,000 that would be split into two $70,000 pots, and that was not specifically named. That was for us to determine. So what our office did is we developed a grant application. We distributed that throughout the state. We received the applications back. We put together a committee to go over that, and we selected 2 other sites to receive that pot of money. And those 2 sites chosen were McDowell County EMS and Wake County EMS. Here's a little breakdown where you can see the 3 different sites right there, McDowell, New Hanover, and Wake. And basically, here's some of the reasons we chose them. They represent the 3 different sections of the state. Our office is broken down into 3 different sections, our east, central, and west. So we broke it down into the 3 regions, and we have a representative from each region there. If you want to look at the population in the counties for those 3 agencies, we've got a good variety there as well. We got McDowell County, which is a pretty rural county, 44,000 folks, all the way up to Wake County with nearly 1 million folks. We got two different system types. New Hanover EMS is a hospital-based system, so the hospital runs everything from 911 and everything in between. And then McDowell and Wake County are governmental-based, county-based systems. And then the other thing we looked at on these three programs is they all have their different programs, and they've been established for a good little while. And many of them do several different things as far as community paramedicine, but they each kind of have their bread and butter, their sweet spot, the thing that they're really, really good at. McDowell County primarily focuses on 911 reduction, on those people, the frequent flyers, the loyal customers. New Hanover being a hospital-based system, they're primarily focused on readmission reduction because that's what hurts their pocketbook. And then Wake County EMS, does a variety of different programs, but one of the biggest things they're known for is the alternative destination. So basically what we did is we allowed them to focus on what they were primarily good at so we could get some more information from them on those programs. Now in that grant, the General Assembly defined that we had to submit 2 reports to them. The first report was due back in June of 2016, and the first report was nothing more than a very general, hey, here are the sites that we selected, here's the process we went through to select them, and kind of a self-evaluation tool that each of those agencies had to do. The final report was submitted this past March, and in the final report it had a little more robust information. The final report included all the data that the agencies collected themselves on all of their programs and the way they do things, and then it also included the state projections. One of the things that I was tasked with in that was trying to make some type of projections as to what it would cost, savings and expenditures if we were to expand community paramedicine statewide. So that's where this kind of stems from. What I'm going to do next is I'm going to show you some of the results from the 3 agencies. I can provide a little bit of information if anyone has questions on it, but primarily I'm going to refer you back to the agencies because this is their information. And then after I present the 3 agencies information, then we'll go more into the state information. So talking about McDowell County EMS, like I said, McDowell's a pretty rural system, primarily looking at 911 reduction. They, between April 1st of 16 and Halloween of 16, they had 230 patients enrolled into their community paramedic program. It's a small program. They basically have 2 full-time personnel doing that. During that time, they estimated that they saved 125 transports, in turn saving 125 ED visits. And what they did is they worked with the hospital there to figure out how much those were worth. And the hospital there basically came up with a figure for them of $102,000 of what they saved in the ED visits and the transport costs. And the graph shows you a little breakdown as to what the insurers were, because obviously our legislators were concerned about how much state dollars is going into each of this, because that's their primary focus. Talking about New Hanover, like we said, is a hospital-based system looking at those readmission reductions. In fiscal year 2016, they saw 824 patients for a little over 3,000 patient visits. You can see 2 graphs below that where it shows the number of days, the average number of days basically from when they were discharged to when they were seen. You can see initially they were at about 7.9 days from when they were discharged to when the community paramedic got to them. We started this grant somewhere just after the first of the year. You can see in January, February, it took a little dive. We got down to 1.9 to 2.0. And then it kind of leveled out around about 4.2 days for the year. So we feel like, the grant obviously showed that a little extra funding can help get some little better results there. So they were able to see their folks on average about 4 days after discharge. Another neat statistic that they put together for us is that for the entire hospital system there in New Hanover County and Wilmington, the readmission rate for the entire hospital was 18%. For the patients that were enrolled into the community paramedic program, of the high-risk patients, which was basically done using a formula based on a scoring formula used off of their current conditions, their medications, all those things, they had a 13% readmission rate for those. So they were 5% better than the hospital average, and that's with the high risk, the worst of the worst. And then for all their patients that were involved in their program, that was 11%. So they did 7% better than the hospital. And 7% in the hospital budget is a pretty good chunk of change. Unfortunately, they were not able to provide us what that chunk of change might be, because I would love to know what that number is. One of the other neat things New Hanover did for us is they also looked at the top 20 users of their system. They took the top 20 folks that called 911 the most there, and they tracked them for a full year. And basically, they went through and pulled the information on them for a year before intervention and a year after intervention. And by considering the intervention being the enrollment into the community paramedic program. So as you can see there, basically, over the course of the year, you see they had a blatant decrease in call volume and transports, inpatient, and of course in charges. When you reduce everything else, you're going to have less money spent on it. And I thought that was some pretty valuable information that we were able to get out of them on that. Next up is Wake County EMS. Wake County, obviously a much larger system. We're looking at about 1 million folks. They looked at primarily at the alternative destinations. The bulk of those alternative destinations were for your mental health and substance abuse patients. In that time frame during the grant, they saw 1,191 patients that met that criteria. And also basically 47% of those folks did not go to an emergency department. 637 of them did go to the ED, but on the flip side of that, obviously you had many more that did not. And I think that shows a pretty tremendous savings there. The pie chart on the right shows an explanation as to why those patients were transported to the ED, because we felt that was some valuable information that we might want to know. You know, not only why did they go to the ED, or where were they going, but why did they go to the ED if they did? And a lot of them, it may have been anything from a medical clearance, as in they had some type of medical issue that they needed to have resolved and you couldn't take them anywhere else. Or it could have been that the facility was at capacity. These are all things that we felt like we needed to track. And so we can see the numbers there is the number of folks that went different places for different reasons. Wake also did a very small pilot with Community Care of Wake in Johnston County. Community Care of North Carolina is basically a healthcare provider, a medical home for a lot of our folks that are on state-funded Medicaid dollars. And basically, they did a small pilot with just 8 folks tracking with Community Care here in Wake County. And they tracked these 8 folks for 1 year pre and post the intervention. And Community Care basically pays their Medicaid bills, so they were able to give us exact dollar amounts to the penny of what they spent prior to the intervention and after the intervention of not just ED costs, but also inpatient costs for those same patients. And we're talking about just 8 folks here, and you can see a pretty significant decrease in the amount that was spent on those folks in the year before intervention and the year after intervention. Again, we're talking about a very small number here with just 8 patients. But at the same time, I feel like it's pretty promising, and it's nice to finally start putting some dollars and some numbers on this, because the bottom line is everyone wants to know a number, and that's the thing that we all have difficulty coming up with, that actual dollar amount. So now we'll go into what we did in our state report. So I basically took the information that we got from those agencies, and we had to try to figure out some way that we could figure out how much money we could save by having community paramedicine in North Carolina if we were to have it all across the state and not just in these 3 agencies. And the bottom line is trying to figure that out is almost unrealistic. I think we all know that every program is completely different. No program is universal. You can't really pick one up and put it down somewhere else and it's going to continue to work the same way. So we felt like it was a pretty difficult task. But in talking with different folks and everything, we felt like there was one thing that was somewhat universal, and I use the word somewhat carefully there, but almost every system has some type of high utilizer, the frequent flyers. So we said, you know what, why don't we try to look at that, because almost any system anywhere could try to focus on trying to reduce the volume of those callers. So then we just had to define what is a high utilizer. Well, you do a quick Google of that, and you will find about 700 different results that give you what defines or what meets the criteria of a frequent flyer. So that was a difficult thing that we had to come to, but we felt like we had to make a stab at it and had to put a number on it. So what I did is I found a report that was done by CMS, and it showed that 4 or more calls or 4 or more transports in a year was what they defined as a high utilizer. We found a few other documents, a study by the National Institute of Health that also used the same number. So we're like, well, this is going to be our best guess, and that's what we went with. Right, wrong, or indifferent, I think we had to pick something, and that's what we went with. The fine folks over at the PIC were able to look through our data and pull out the number of folks in North Carolina that met that criteria. So in 2015, there were 17,763 people who met the definition of a high utilizer, using that definition of 4 or more times in a year. Those 17,000 people called for a total of 141,000 times, and that led to 103,000 transports over the course of that year. So then what I did is we took those numbers that I received from New Hanover and from Wake in the reduction of frequent flyers, and basically applied that to those statewide numbers. And I used it basically as a range. Using the Wake and New Hanover numbers, they were a little bit different, but I felt like they were fairly close. So it kind of gave us a minimum and a maximum that we could go with, and we felt like, obviously somewhere in the middle would be a little more realistic. So if I apply that percent change to the number of calls, we felt like we were reducing call volume 46,000 to 52,000 calls a year, and that we could reduce transports by somewhere between 28 and 40,000 calls a year. Now, that's assuming obviously working in a vacuum and a perfect system and everything's the exact same, so we know there's obviously a lot of limitations there, but we had to try to make some type of estimation for across the state, so we did have some of these assumptions that we felt like we had to make. And just to try to better illustrate that, Tony put together a little graph here that shows the estimated savings in that reduction of call volume and the reduction of transports of what it was before versus what it would have been applying those numbers. Now, I will say that percent change in the transports and the call volume, anywhere from 28% to 38% on the high end. If you look at the community paramedic report that came out from the state of California, I believe it was, this past year, they showed some similar numbers in theirs. I want to say theirs was about 31, 32%. I don't remember exactly off the top of my head, but it was somewhere around that. So I was at least comforted in knowing that there are other folks that are getting similar type results when looking at the frequent flyer reduction. So I feel like that number is not too much of a guess there, too much of a wild number. So then came the real tricky part, is they want to know dollars. These numbers are great and everything, but it all boils down to the mighty dollar. It runs everything. So what I did is I had our folks over at Medicaid here in the state, the DMA, they provided me the rate for the average transport for every county in North Carolina. So then I took those folks that were deemed to be frequent flyers, those 17,000 folks, and I figured out where they lived, and I applied that same percentage across those people, and it helped give us a number of what it would cost just in saving in transports. So we said, we would save between 28 and 40,000 transports a year, and based off of where those people lived, we felt like that, just in transports alone, we were looking at somewhere between $2.1 and $2.9 million saved by not transporting those folks to an emergency department. Obviously, that's not including expenses, because there are expenses to operate these programs, but that is the cost to save to not transport them somewhere. Obviously, with it being state dollars, the biggest thing they're concerned about is how much they're putting into it. So that's why we looked at the Medicaid-only participation. And we don't know what percentage of folks this would be for Medicaid, but we basically applied 17.9%, which is what it's the distribution for the entire state of North Carolina. So we assumed that basically it's the same percentage of folks throughout the state that would be using the system. I know a lot of folks tend to say that it's probably a little bit higher on the Medicaid end that using the program. So maybe our estimation's a little low there. The other thing they wanted us to try to go from there is, that number is nice and all, but obviously we're saving more than just the cost of the actual transport itself. We're also saving a lot of other things, such as the ED cost, inpatient cost, and all these other things, and those are really difficult to calculate. But what we did try to do is we tried to look at what just the ED cost would be. So if we took those same number of people that were transported, and we applied some ED numbers to it, we came up with some numbers of what we could save by not taking them to the ED. Now, the two numbers I used were 1233 and 189.16. The 1233 basically came from some research I found that showed that that's the average cost of an ED visit. How valid that is, I have absolutely no idea. I felt like the source was fairly reliable, and it was the best thing I could come up with. So that's where we went with that number. And it seemed to be noted in several other journals that I'd looked at. The 189.16, that is the cost. That is the actual amount paid out by Medicaid in North Carolina for the top 3 claims to be seen in the emergency department. So if you are a Medicaid patient and you go to the hospital for one of the top 3 things, which was like abdominal pain, respiratory distress, and I think traumatic injury, they average pay $189. So they're getting quite a deal for those services there to go to the emergency department. So that's where those numbers came from. And I basically applied that to that same number of people that we said we weren't going to transport. And that's where we came up with the numbers here on what you could save anywhere between $35 and basically $50 million in just ED cost. And obviously that, we haven't even gone into inpatient because we had no idea how we would even start to track those costs. And there's a little graph just showing the statewide savings that we would have, like I said, anywhere between 2.1 and 2.9 million just using the transport cost, using the Medicaid numbers. I feel like those Medicaid numbers are pretty conservative. Medicaid in North Carolina on average, I mean, they gave us a specific amount for every county, but on average it worked out to about $70 for an ambulance ride. I think we know that most of our other payers pay significantly more than $70 for a ride in an ambulance. So we use that number for everything. So that number very well may be quite conservative there, but I felt like that was probably a little safer than trying to shoot for the moon with a real big number. So we add it all up right here, and basically here you can see what it would be if you added the ambulance transports plus the EDs, and that gives you your two different type groups right there, anywhere from 37 to 52 million. And then looking at just the Medicaid population, which would be the state dollars, which, like I said, the General Assembly is concerned about, anywhere between 1.3 and 1.8 million in just Medicaid dollars. But obviously there's some expense to that. Now, the expense they're looking at is a little different than the expense our providers are looking at. The providers are looking at the cost of equipment and personnel and training and all these other things. Well, the state, the General Assembly is not necessarily looking at those direct costs. They're looking at how much do you want to do this service. So what we did is also this past year, Division of Mental Health ran a pilot program in North Carolina with community paramedics, paying for alternative destinations. And basically they paid $164 on a trial basis for any patient that you went to go see in your community paramedic program and did not transport to an emergency department. So I use that same $164 number as an estimate of what it would cost for these programs. I figured that if that number was good enough for them to use in their study, then by God, that's the number we're going to use for ours. So applying those same number of transports, that 28,000 to 40,000, I applied that $164 cost to those, and then you can see what it would estimate it would cost if we had billed for the service. It's basically a trial reimbursement. Like I said, that's anywhere between 4.7 and 6.5 million. In just Medicaid dollars, you're looking at 800,000 to 1.1. And then there's our net savings. Let's look at what is our savings minus our expenses. So obviously we've got a huge range here, anywhere between 510,000 to 700,000 or 32 million to 45 million. That is a gigantic range there. So obviously I think it shows that we need to do quite a bit of work to get a more accurate number. So I will talk about, obviously there's a ton of limitations, and these are just a few of them. And I have no problem admitting there are lots of limitations to any of this research. But, someone kind of had to take a stab at this, and we had to put a number to it. And it's been really difficult to find anyone who kind of was willing to go out on that limb. And we said, well, you know what? I've been wrong before, and I'm not afraid to be wrong again. So let's see if we can at least make a stab at it. Some of those limitations that we came up with were obviously, this just looked at community paramedicine savings as far as the reduction of high utilizers. There are so many more avenues, as you're all well aware of, that actually go into this. And those savings in those other areas may be much, much larger dollar numbers. But this was the only thing I felt like I could really apply somewhat evenly across the entire state, that it didn't matter where you lived or how far you were from a hospital or what size community you were in or any of those types of things. As I mentioned, there's a very substantial cost savings estimated here. It's a very large range. And that big range makes it difficult to pin down what you actually truly would save. And I'm hoping that's kind of what my point was to some of the folks reading the report in the General Assembly, is that we need to figure out a little more. We don't know exactly what it might be because we were kind of pigeonholed into this. These estimates are very broad and make a lot of assumptions. And basically the bottom line is we do need to do more research on some of this. One of the things I mentioned before is that using those DMA figures on all payer groups, there are probably actually some conservative estimates for some of this. So maybe these giant numbers are a little conservative and they're actually much, much larger. And that would be fantastic. I think that would further back our claims. But we had to, I think, go a little conservative to start with. And as I mentioned too, this is just EMS transport savings. We're not even looking at inpatient costs and all the other associated things that you could save by not taking someone to an emergency department. And then we also have to consider other costs, because if we don't go to an emergency department, they go somewhere else. There is a cost to some of these other places, some of the other alternative destinations and other treatments. They have costs associated with them. But we don't really have a good way right now of measuring that, and that's something we need to consider trying to track and measure going forward. So with that, that's pretty much the bulk of our whole report. Tony only presented a small portion of that at NCOEMS, just because we only wanted to focus on the state data, because the other folks, they own their own data there. But having talked with them, and given the fact that this presentation was a little more on the entire grant, I didn't have a problem at least showing you some of their numbers that they had. Here's my contact information, as well as, like I said, Dr. Tony Fernandez over at the PIC. Tony works quite a bit with us, or all the PIC staff does, works quite a bit with us on some of this stuff. And either of us would be glad to help anyone that has any questions, comments. I'd love to get some feedback if anyone has anything on ways that we could try to improve this, ways that we can go better. We're looking into trying to see if we can organize this a little better and try to see if we can publish somewhere and go from there. But I think we had to take a shot at it. And with that said, I think I'm about done. I'll be glad to open it up to any questions, comments, anything anyone might have.
Well, thank you, David. This is Kevin McGinnis back. Two fascinating presentations. One more worldwide, and predictions of where education in the future is going and practice in community paramedicine, and the other a study that may help shape what we know about the impact of community paramedicine from a number of different approaches. Let me open it up. Gary, will you unmute all of the lines, please? We don't have anything in the chat box yet, but now
the conference has been unmuted.
Now you have an opportunity to simply speak up. Please introduce yourself and who your question is for.
I mean, I can bring you one, but hell, it'd be 4:30 before I got there.
Any questions for Gary or for David?
I think I put them all to sleep.
I don't think so. Let me juice the works here then. Gary, the figures that you had on North Memorial's program, I see have produced even more savings in the last year. Can you just tell us a bit more about what those dollars represent and what EMS that's participating in that program gets out of those dollars? What can they spend it on?
Yeah, so it's an ACO model, and so I don't want to leave you with the impression that all of that savings was generated by the community paramedics. They're part of a care team, but it's the ACO model that produced those savings, and the community paramedics were a part of that. In that model, the paramedics are assigned to specific clinics within the North Memorial system, and they do a huddle with the staff, often by telephone, at the beginning of the day, where everybody talks about the patients that are going to be seen that day, and then the people in the clinic go see the patients that come to the clinic, and the community paramedics go see the ones that they're assigned that are in the home. So it's really up to North Memorial to decide what they want to spend that savings on. It's a bonus check from our state that could have been zero. I don't think they're in a negative risk environment. Obviously, they don't have to worry about that even if they were. But it's a check from the state, and it's in addition to the funds that they were paid to see the patients that they saw. So it's up to them to spend, best I know it.
Great, thank you. Are there other questions from the audience?
There's one in the chat box.
Aha. For David, do you have any numbers on savings due to cost avoidance? Number of reduced 911 calls times dollars.
We don't really. The little bit that we had on that was actually what McDowell did on their 125. It was not so much that they saved that many transports. Those were the number of avoided transports that they anticipated based off of the prior history. And like I said, that was about 102,000 that they saved out of those calls there. I do not have any further information really on that. McDowell themselves may have some more information, and I'd be glad to provide you with their contact information if you'd like to reach out to them directly.
All right. Other questions?
Kevin, I have one for David. Sometimes I hear people talk about when evaluating the cost avoidance balancing metric, where you might still, even though the emergency department was less busy that day, they may have still had to have the same number of staff on duty. So the hospital still may have been paying out salaries that were just salaries, seeing less patients. I haven't really heard that personally from a policy person, but it does come up in conversation. And I'm wondering if you heard anything about that from either the lawmakers or the Medicaid people or anybody in the program that you worked with.
No, I haven't heard that. The only thing close to that I've heard is they talked about bed hours, in particular in regards to the mental health patients and the alternative transports. They talked about the number of bed hours someone would sit there, but never on staffing levels with that. And I think that would be some interesting information to try to look at further, but I'm not exactly sure where we would get the information from.
Yeah, I'm not either. That's I was sort of hoping you might have heard it, so maybe we could dig into it. But
have there been discussions about that, Gary, in the venue of the community paramedicine mobile integrated healthcare performance measures development?
yeah, we did talk about balancing metrics in there, and there's a section on it. Off the top of my head, I can't tell you exactly what it does, but it was a point. That's exactly where it came up.
Okay. Yeah, maybe some further research there.
Yeah.
Other questions?
So, Kevin, as you're looking for people that might have results to share, if anybody knows of some place that has had to do that exercise, that would be a really good one for us to put on sooner rather than later.
That's a good point. All right. Well, hearing no other questions, I'm going to call it a day for the month. We will be back with you in May at the same time, the third Monday of the month at 3 p.m. And for the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, the Center for Leadership, Innovation, and Research, I bid you good day.